Good afternoon. I'm Dr. Johnathan Bernard. I'm a sports medicine specialist, shoulder surgeon, knee surgeon with OrthoVirginia. Thanks for joining me this afternoon. For those who don't know, OrthoVirginia, we're the largest orthopedic practice across the entire state of Virginia. We are a multi-specialty orthopedic practice, which means we have a little bit of everything. I don't want to bore you talking about OrthoVirginia. I could talk about it all day, but go to our website, OrthoVirginia.com, if you're interested in finding out more information. But today we're focused on frozen shoulder, a topic near and dear to my heart. I like frozen shoulder a lot, and so I'm here to answer any questions that you have, questions for yourself, questions for your family members. This is a Facebook Live event, so feel free to share the link. You can send it to anyone, and then, of course, purpose is to be interactive and to ask your questions, so go ahead and fire your questions away. I'll just start with a little bit about frozen shoulder or adhesive capsulitis. A lot of people are familiar with the term. People have been diagnosed with the term. I'm just going to tell you a little bit about what it is, how we diagnose it, how we treat it, and what options are available for you. Frozen shoulder or adhesive capsulitis. We don't really know exactly how it causes, why it occurs, but basically the inside lining of the shoulder, which is called the synovium, slowly starts to freeze. It gets very, very inflamed, and it basically creates what's called a contracture. A contracture is just stiffness inside the shoulder, so that's why we call it frozen shoulder. And it can happen, we have some risk factors. Surgery can cause it, being immobilized, an injury can cause it. Certain medical conditions like diabetes or thyroid conditions can cause it. We also know it occurs more in women than men. But basically, all those risk factors come together. You slowly start to freeze the shoulder, and it goes through 3 different phases. The first is sort of this freezing phase, where both when you move your shoulder and at rest it hurts. Once it goes through this freezing portion, it's now frozen. And you don't have pain at rest, but you have pain when you move it. And then eventually it thaws out. It slowly loosens up. What's fascinating about frozen shoulder is that these 3 distinct phases can take days to weeks or even months. So this first phase of being painful with both active and passive range of motion, it can last 4 months, 9 months. Once it's frozen, it can stay frozen for months. When it thaws, it can take a while to thaw out. And I credit Dr. Johnathan, where I trained at Hospital for Special Surgery, HSS. She did a lot of the groundbreaking work on discovering, exactly how this occurs and how to treat it and what to do. And so early on in this freezing phase, there are a lot of studies that show if you do a cortisone injection, you can actually stop it from freezing. So you don't have to wait the months. You stop it from freezing. There's a role for therapy, so October is physical therapy month. Shout out to all the therapists that I work with. They're excellent because once it's diagnosed, once you get into this freezing phase, and once you start to thaw, when it's less painful, you can do physical therapy to stretch that shoulder capsule out. And so there's a role for therapy. Therapy is how we treat it. Once the diagnosis is made, therapy is what we do to stretch that shoulder out and to get your function back. We often will get x-rays because there are other things that can also cause stiffness in the shoulder. I like to think of what's called a differential, everything that could possibly cause shoulder pain, and I kind of categorize it with either pain, weakness, stiffness, instability, and we group all these differential all together, and x-rays is what we look at. You can't see frozen shoulder on an x-ray. Okay, you can see impingement, you can see rotator cuff problems, you can see arthritis, you can see what's called calcific tendinitis, but you can't see frozen shoulder on an x-ray. It's really the physical exam when we look at the shoulder and examine the shoulder, how we determine if someone has frozen shoulder. And one of the classic things I see on physical exam for a frozen shoulder is that your external rotation, which is when you move your arm out to the side, when your arm is directly at your side, you lose your external rotation first. So you compare it to the other side might have a lot of range of motion, you lose your external range of motion first. The other thing that I also see is that your active and passive range of motion are equal. So when you raise your arm, or if I were to try to raise your arm, both are equal. Things like a rotator cuff tendinitis, you might have some weakness, but passively you should be able to get the rest of that range of motion. And so adhesive capsulitis is one disorder. When it occurs, that is very much present. Typically, like I mentioned, therapy is what we do to treat it. If therapy isn't really working after 6 weeks, 8 weeks, or I'll often say better, worse, unchanged, if you're really plateaued or you're not improving, an MRI would sort of look at the details of ligament, tendon, cartilage, bone. MRI uses magnets to kind of line up tissues. It gives a different set of information than x-rays. And like I mentioned, surgery is way down on the list. Oftentimes it's really in the setting of something not improving or in the setting of another injury that is also causing some pain and discomfort. There's some exercises, stretches that you can do on your own. Many times the therapist will work with you with some manipulation or a home exercise program. Some exercises that I like involve taking a broomstick and kind of moving your shoulder around, using your other arm to help you. Some of these exercises you can do while laying down, which will hold your shoulder blade in place, and that forces the range of motion just through your shoulder joint as well. Another exercise that I like is taking your fingers and walking them up the wall. That allows for some active and active-assisted range of motion. Another one is using your other hand, squeezing your shoulder blades together and bringing your arm up first to the top of your head, and you can rest, and then going above the rest of your head to help with that range of motion. All right, so that summarizes just a little bit about frozen shoulder. Again, adhesive capsulitis, reasons we don't truly appreciate why, but we know how. It basically, inside lining of the shoulder starts to freeze. If you get to it early with a cortisone injection, it stops that freezing process. Eventually it will thaw. The mainstay treatment is physical therapy, and shout out to our therapist for Physical Therapy Month of October. Many instances it improves with physical therapy. X-rays and a physical exam help diagnose it, make sure there's nothing else that are taking place. MRI is reserved if you're not improving, and then there's a number of different things that we can do, whether it's what's called guided injections to distend the shoulder, or even surgical treatments, which is what I would do, an arthroscopic approach to release some of that scar tissue, or address any of the other things that are also causing shoulder pain within the shoulder. So that wraps up my portion of describing frozen shoulder. I'd love to hear from you guys. Any questions that you have, feel free to send them my way, and I'm happy to answer them.
Awesome. So we have a few questions to start.
Perfect.
All right. Can you please talk about whether strengthening the deltoid muscle and the muscles around it is helpful and will not cause additional damage?
Absolutely. The deltoid muscle helps bring the arm up. I have a shoulder model right here. So this is the shoulder. There's 3 bones to the shoulder. You have your collarbone or your clavicle, your scapula, and your humerus or your arm. This forms the shoulder joint. Your deltoid muscle is a lever arm. It attaches over on the outside. It helps bring your arm straight up into the air. And so strengthening that deltoid muscle allows for that arm to have better range of motion. There are also a series of rotator cuff tendons. Tendons attach muscle to bone. There's 4 of them. Strengthening those rotator cuff tendons as well as the scapular muscles attached to that scapula helps center the shoulder, which allows for better range of motion from within the shoulder joint itself. Many times if that deltoid muscle is weak or inflamed, the kinematics, which means how the shoulder moves, can be altered, and it's very difficult to restore normal function if that deltoid is weak or impaired. And so it's one of the first things we try to do. We activate the shoulder, we activate that deltoid to get that shoulder motion to move a little bit better, and by doing that it allows for better function throughout the shoulder as well.
Awesome. Can you address whether chiropractic or manual therapy can help get the shoulder loosened up so that pain starts to diminish?
Yeah, so when we treat adhesive capsulitis, we look at the different phases of frozen shoulder, and we try to anticipate what intervention will work best at what phase. I actually discourage any sort of manipulation during that freezing phase. Why? Because it's going to be really painful. It's going to be really painful. And so that's when there's a role for a cortisone injection, or waiting until you're not actively freezing. So any aggressive therapy during that freezing phase will actually be pretty painful. There's a lot of great chiropractic manipulation once you're starting to thaw. Once you're starting to get the rest of your range of motion back, manipulating the shoulder, putting pressure in certain areas is very helpful. We'll sometimes do what's called a manipulation under anesthesia. So for folks where the therapy hasn't reached the desired results, we'll actually do what's called a regional block, and so we'll kind of numb up the nerves. We'll gently press on the shoulder. We'll get an x-ray to make sure there's no fractures or anything like that. And when I do that, I'll have patients go immediately to therapy, and there's a role for lots of chiropractic manipulation at that time, really because the muscles can really contract, and even though the scar tissue is broken up, the muscles may want to return back to that setting. And so there definitely is a role for both a home exercise program as well as lots of manipulation to maintain the range of range of motion that you get. Mm-hmm.
Awesome. All right, next question. I've had 2 previous frozen shoulders, and I believe I have another. The doctor I saw pre-COVID said I had bursitis or tendonitis and gave me a prescription for meloxicam, which I took and did exercises for 3 months. What exercises do I do to break the adhesive capsulitis free?
Yeah, so sorry that you're getting it twice and possibly a third time. Bursitis is inflammation of the bursa. You have many different what are called bursas throughout your body. It's basically a potential space where 2 surfaces rub together. And so in the shoulder, there's a few areas where you have a bursa. Right underneath this bone called the acromion, there's a bursa. The deltoid, again, that muscle that's over here, has a bursa as well, the deltoid bursa, and both those can get inflamed. And so things like meloxicam, which is a non-steroidal anti-inflammatory, or an NSAID, helps reduce inflammation in tendons as well as bursas. As I mentioned, Dr. Hanifin did a lot of studies looking at adhesive capsulitis. Because adhesive capsulitis is a problem from within the capsule, which is inside the shoulder joint, we know the treatment of early adhesive capsulitis is a cortisone injection, which is different from an NSAID. Cortisone's a steroid. Steroids are naturally produced by your body. When we put steroids into potential spaces like bursas or even inside the joint, they act on the lining inside the joint, and that helps eliminate that process. Adhesive capsulitis is what's called self-limiting, which means if you do nothing, it will stop. We know that the cortisone gets it to stop, especially if you continue to freeze, and that freezing process can be undetermined. In some patients, it's been reported 2 years, and so that's where the role of cortisone to stop the frozen shoulder inside the shoulder joint is a little different from the bursitis that might affect the tendons or even the surfaces underneath the bone.
Awesome. So next question, how does one know if it is frozen shoulder or the cartilage is worn out?
Also a great question. So as I mentioned earlier, one of the telltale signs of adhesive capsulitis is when you lose your external rotation with your arm at your side. So if your arm is neutral and you bring your arm out, comparing it to the other side, adhesive capsulitis, you're unable to move it. Well, arthritis can actually cause that loss of range of motion with your external rotation with your arm at the side. Unlike adhesive capsulitis, which has no appearance on x-ray, arthritis does have an appearance on x-ray. And so that's another reason why we get x-rays of the shoulder, because we can determine if it's arthritis versus adhesive capsulitis that's causing loss of range of motion.
Awesome. So next question, is there a risk of long-term complications?
There's no specific risk of long-term complications from adhesive capsulitis. I think what I often will try to decipher with patients is the source of their pain. If their pain is coming from the frozen shoulder, if the source of pain is coming because of stiffness related to the frozen shoulder. As I mentioned, x-rays give us a good sense of ligament, tendon, cartilage, bone. You can sometimes have bone spurs that can rub on the rotator cuff tendon. And if you lose range of motion from frozen shoulder, you can make things like a rotator cuff tear worse, and certainly less functional. So no, from adhesive capsulitis, because eventually you unthaw, sometimes your range of motion doesn't match your pre-adhesive capsulitis or pre-frozen shoulder range of motion, but it's really to make sure that there's nothing else in the shoulder that could potentially cause changes to your shoulder and how your shoulder functions.
All right, so could a sudden movement, in this case reaching back to push a seatbelt release button, lead to a frozen shoulder?
Yeah, I've seen some patients do exactly what you're describing and trigger a frozen shoulder. Like I mentioned, it can happen as something as innocently as a life event, reaching behind your back, reaching for a seatbelt, reaching for an object, and kind of triggers. It starts that fire, almost like dry kindling inside the shoulder. It just needs a spark, and then once it gets inflamed, it can lead to both your active and passive range of motion being affected. But that is a common complaint. I do see some patients that are like, I never really injured my shoulder, but I noticed when I was reaching for my seat belt, or in women I was reaching behind my back for my bra, I was doing something, what we call activities of daily living that can trigger it.
Awesome. How can you prevent this from happening on the other shoulder?
There is, and there are a lot of patients that report it from occurring bilaterally. There's no real prevention per se that you could do. It's really unlucky. Really unlucky. Yeah.
Oh. So, a question about cortisone shots. How often can you get a cortisone shot?
Yeah, so depends on what you're doing it for. For adhesive capsulitis, you really just need one cortisone injection inside the shoulder joint. There is a role for injections to other locations. For example, we spoke about the subacromial space, so that's underneath the shoulder blade. Sometimes we'll do an injection for the frozen shoulder, but as you're recovering, you can get a tendinitis or a bursitis, and then the role for cortisone in that location is different. I've had a few patients that I've needed to do more than one cortisone injection for. I'll sometimes do an image-guided injection with either use of an ultrasound or a fluoroscopy or X-ray machine to confirm the location. Sometimes we'll get the injection at the time of the MRI with what's called an arthrogram. I'll often describe injections as being diagnostic as well as therapeutic. Diagnostic because the numbing medication tells us if we're in the right spot. I'll tell patients keep track of how much pain relief you get. Therapeutic because in the case of adhesive capsulitis, that is the cure, to get it from freezing. Having said that, if you're thawed out and your range of motion hasn't been quite there, you're having some pain in certain other locations in and around the shoulder, there are many little pockets inside the shoulder too that you can inject with cortisone. There's a concern if you do too many cortisone injections, it leads to a rupture, it leads to some cartilage loss, and so really in my mind, if you're doing a lot of cortisone injections, and I'm not a big cortisone person, I think for something like adhesive capsulitis, it absolutely makes sense. You really should evaluate what you're injecting and to what purpose, and to figure out if it's something that wouldn't improve with therapy and you need to get an MRI, or if it's something that through therapy, through chiropractic manipulation, through modalities like heating and cooling, icing, topicals, if it would improve.
Awesome. So I also have tightness in the neck in the morning. Can that be related to frozen shoulder?
I would say indirectly. When the shoulder starts to freeze and you lose the motion through your joint, you can get a lot of extra motion through your scapula. And so when your scapula really starts to move, some patients won't even know that they have frozen shoulder until a physical exam. And one thing I do is I'll have patients lay down, which holds their shoulder blade in place, and it really forces the motion through their shoulder joint. The scapula is the shoulder blade. It kind of rubs in the back. When it moves a lot, especially if you lose motion in your shoulder joint, you certainly can get neck pain, neck tightness, fatigue, because those muscles aren't used to using and to be levering the arm in the way that they're doing it. I would say if you have isolated neck pain or stiffness, you should get an x-ray of your neck to make sure you don't have arthritis inside your neck, which is also a separate and very common condition that can occur that's irrespective of a frozen shoulder.
Awesome. So this is an interesting question. How common is frozen shoulder associated with autoimmune disease like diabetes? Could it be a sign or symptom of diabetes?
Yeah, great question. I would probably say it's the other way around. So I wouldn't necessarily say we are making a diagnosis of diabetes based off of the appearance or finding a frozen shoulder. Many times it is a risk factor. So risk factor means that it is something that we see diabetics are more frequently having a frozen shoulder, but not necessarily the other way around. I think there's some other more sensitive and more specific signs for both autoimmune disease as well as diabetes that are more likely to make a diagnosis for those conditions. But we do know that there are some risks and some risk factors associated with frozen shoulder. Being a diabetic, we see more diabetics have frozen shoulder than those that aren't. Thyroid, so hypothyroidism is associated with frozen shoulder. Having a previous injury, having a previous surgery, and women. And so we're more likely to be mindful in those situations. For example, if a patient comes in and they have some shoulder pain and they're a diabetic and they don't necessarily have all of the signs of a frozen shoulder, instead of me saying, oh, let me see you in 6 weeks, I might say, let me see you back in 2. Like, let me keep a closer eye because I'm aware that this is a risk factor associated with it. I wouldn't say the opposite. If a patient came in with frozen shoulder, I wouldn't say, oh, maybe you have diabetes, let's send off some blood work.
Mm-hmm. Awesome. So my pain goes down my arm and feels like it catches down where my bicep and tricep come together on the top side of my arm. Is this something that is present with frozen shoulder?
It can be. Again, with frozen shoulder, you start to lose your range of motion. I often will describe primary and secondary pain within the shoulder. Primary pain might be as a result of stiffness. Secondary pain might be as a result of compensation. You know, you're moving differently, your range of motion is decreased in order to reach for something, you're using other muscles that you normally wouldn't, and then that can lead to secondary pain, secondary problems.
Awesome. So we have a question about night pain. Yeah. Their pain is unbearable at night while sleeping. What are the best ways to manage pain at night?
A lot of shoulder issues, you get night pain. Rotator cuff tears, adhesive capsulitis. After shoulder surgery, night pain can be very challenging as well. If medically safe, an anti-inflammatory would certainly help with inflammation by reducing that inflammation. I'll have a lot of patients sleep upright after shoulder surgery or with adhesive capsulitis. Sleeping propped with several pillows or even in a recliner can really help with that night pain. Icing can help as well. 20 minutes on, 20 minutes off, sleeping with ice packs, sitting upright in a recliner, and taking an anti-inflammatory can certainly help.
Awesome. After more than a year, I no longer have pain and movement has come back to about 80%. PT early on made it worse. At this point, should I just do stretches and strengthening? Is there a way to prevent this from happening again in the future?
Yeah, so great points. I think your question illustrates many of the elements that we're talking about. Basically, there's 3 phases. You may have started therapy in that early phase when you're still freezing, and I would agree with you. I see that often. A lot of patients say, you know, I was doing therapy and it was worse, and while you're freezing, it is quite terrible. But once you're far enough out, and it sounds like you're thawing at this point, you've already gone through phase 1 and 2, you're probably in that 3rd phase, you're restoring the rest of your range of motion. This is actually the time for therapy. This is the time to really use therapy and to be quite aggressive as long as you're not having pain to get the rest of your motion back. Many times, and what we measure can be crude. We measure your forward flexion, which is bringing your arm straight over your head. We measure your abduction. We measure your external rotation at your side and at 90 degrees. The last bit of range of motion to come back is your internal rotation, and that's the hardest thing to get. There are some what are called sleeper stretches that you can do where you're laying on your side and you're kind of pushing your arm either an external or internal rotation, and it sounds like if you have 85% of your range of motion, you probably have it mostly in all those degrees minus that internal rotation, and that's where a role of a good therapist to kind of help coach you along and identify if there's pain that's limiting, what is limiting, and really giving you a good home exercise program to improve.
If the shoulder is already frozen and through PT the acute pain has been drastically reduced, what benefit would a cortisone injection give?
It depends on where. So sometimes if you're past that acute phase, you're frozen, and you're getting ready to thaw, you're starting some therapy. Sometimes we do cortisone above the shoulder to kind of help things. Sometimes we'll do cortisone inside the shoulder joint so that you don't lose progress. I would agree the purpose of cortisone is not to prevent the freezing at that point, but it would really be as what's called an adjunct, kind of helping assist the role of therapy. It's in that phase, that third phase, that if you're already frozen, you're not really getting a lot of gains, we'll sometimes do that manipulation under anesthesia. And then what I'll do is a cortisone injection after the manipulation while you're still asleep to kind of help with any post-manipulation inflammation that you might get.
Awesome. So a follow-up question to a question we had earlier. The meloxicam did not help at all. I can't get my arm across my chest or behind me. So will a shot help now?
It probably, yeah. And I think if you were seen by an orthopedic surgeon, they'd get radiographs. They would assess you, obviously make sure that it's not coming from your neck, which is also a common source of both pain, radiating pain, weakness. It can masquerade as a frozen shoulder. But if appropriate, I would agree with cortisone as the next step to help the physical therapy.
Awesome. Will massage in the area help?
Depends if the massage is treating the secondary pain. Massage as a treatment for adhesive capsulitis or for frozen shoulder is not indicated.
Okay. I have surface tearing, mild thickening in my rotator cuff. They said it may be frozen shoulder. Will I need arthroscopic surgery?
Without really knowing too much detail, hard for me to recommend surgery for adhesive capsulitis. The treatment for adhesive capsulitis is physical therapy. There are some instances where there may be injury inside the shoulder that hasn't improved with physical therapy. Rotator cuff tears typically would require surgery if failing therapy or if the tendon were detached from the bone. Because tendons attach muscle to the bone, the muscle tends to pull on tendons. Of course, there's some patients that have asymptomatic rotator cuff tears. Complicated question. But I think simply put, the surgical treatment for adhesive capsulitis is more rare than common, and many times we try a lot of different things first before recommending surgery.
Awesome. All right, a couple more questions, and we don't get to your question today, we'll follow up. Do topical anti-inflammatories work?
I love topical anti-inflammatories. They do work. Depends on the location. They work particularly well in hand and in the wrist, around the knee. Everyone's shoulder is a little bit different. There's a lot of space in the shoulder. Any modality that helps reduce inflammation is very helpful. In the shoulder, there's only a few prominent areas, really around that clavicle bone, the AC joint. If there's a lot of inflammation underneath the deltoid, then the topical can certainly work there.
All right, last question. Should the anti-inflammatory be taken in regular cycles or just when we feel the pain at night, for example?
Yeah, that's a great question as well. So anti-inflammatories, like any medication, have side effects. Even though things like ibuprofen and Aleve are over the counter, if taken consistently over many months, can cause kidney problems, stomach problems, can cause ulcers. Patients with high blood pressure can lead to blood pressure issues. I typically start by just saying as needed. When you're doing a lot of therapy and you're still having a lot of inflammation, you could certainly do a round of an anti-inflammatory almost consistently for about 10 or 12 days, and I tell patients if you're having any side effects, stop taking it. But if you did it consistently, almost like an antibiotic, as long as you're taking it with food and it's not causing any other side effects, you could see how the cumulative effect of the anti-inflammatory can help reduce the inflammation. And then I would say take a holiday. Come off of it, make sure that you're not having any other side effects, and then you could certainly do it as needed after that. Typically that cycle, if you were to do that cycle, it brings you to about 4 to 6 weeks, and if you're still having a lot of pain after that, you should probably either be seen or evaluated, consider a cortisone injection, and at a minimum get x-rays to figure out what else is taking place.
All right, that's all our questions.
All right, well, perfect. This sort of concludes everything. I hope you learned a lot. Thank you for sending your questions. Thank you for participating. Again, my name is Dr. Johnathan Bernard, sports medicine shoulder surgeon with OrthoVirginia. You can follow us either on Facebook or go to our website, orthovirginia.com.